So we'll wait for another 1 or 2 minutes. Dr. Malika, please. Volume, full volume. So this happens after corneal cross-linking. So we'll be just waiting for judges to come. And meanwhile, I request all the presenters, they have to be on that podium while their presentation is there. First, there will be video will be displayed, and they will be asked maybe a few questions by the audience or by the judges. And based on that, the marking will be given. It will be seen how useful is to the audience, how the tape is going to help them in the practice. So, sir, if you permit, we can start, or we should give. See, this is the last session, and most of the person has to rush for a flight. And on my request, they will stay here, and they are just having a tight lip. So, without wasting a time, we'll basically have to change a little bit, since 1 or 2 person has just on the nick of time, they have to change the things.
Submacular.
So I'll invite first Dr. Ashok Sharma.
We can't afford to charter a flight for him.
So sorry for this.
Sir.
Okay. Please.
Hi Sharma, let us go for fishing out deep corneal foreign bodies. Wow, you know fishing. I doubt it. I shall teach you fishing, as both need patience and perseverance. Let us take up the first case. You can see the foreign body. We will open and widen the track. It is not possible to hold and remove, we will scoop it out. Here it comes out, wonderful. So, the first lesson, put a barrier and do not let your catch go into the deep waters. Let us go to the second case. Oh, so many fishes, foreign bodies. These are full thickness vertical wooden and need to be removed in toto. So, to catch many fishes at one time you need different strategy. I shall go deep, enter the anterior chamber, push these from behind and pick up one by one. Let us start the third one. Oh, Sharma, you have become an expert. Yes. I have a silvery fish, a metallic foreign body. It is a tricky one, we will wide open the track and pull it. Not successful. Does not matter. Let us go inside like the previous case. Here I do not find. So, I found it is there deep in the anterior chamber. Let us increase the entry and use retina faucets to remove. Wow, wonderful. So, now, you understand, both fishing and fishing out deep corneal foreign bodies need patience and perseverance.
Chicka boom chick chick, boom 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 chicka boom. Boom chicka boom chick chick, boom chicky boom chick chick, boom chicky boom chick.
Thank you. Any questions, Malika?
Yeah, definitely. We do everything, but this is just the surgical part we are showing.
Thank you. Thank you, Dr.
Okay,
Ashok.
sir. Thank you.
Have a wonderful flight.
Can we have the presentations? So I'll request Dr. Manik Sardana to come here. Dr. Manik, please. So we wanted to start it with bang, but Dr. Ashok has to go. So bang comes now. Band tabak interno-needle goniotomy bang with phacoemulsification in PACD with cataract.
This is my experience of bang as a senior resident. So first a 24 gauge needle is bent. The distal 0.5 mm is bent towards the bevel. So this was a challenging case. Patient's ACD was very shallow. The patient had a patent PI. So after preparing the patient, tilting the microscope and tilting the patient, using a direct gonio lens, the angle structures are visualized. So it is important to visualize and demarcate all the angle structures, first in low magnification, then in high magnification. Then the goniotomy is entered into the anterior chamber and the trabecular meshwork is excised. We can nicely see the trabecular meshwork floating in the anterior chamber and the posterior wall of Schlimm's canal is also visualized. So this is a very easy to learn, inexpensive mix for all anterior segment surgeons, which can be performed along with phacoemulsification. Then after performing bang, a routine phacoemulsification is carried out. We can see the shallow anterior chamber in this case. Multi-quadrant hydrodissection is done. Then routine phacoemulsification is performed. IOL is planted in the back. Thorough removal of viscoelastic and any hyphema is done. So post-operatively at 1 month, the patient had a best corrected vision of 6/6, and the intraocular pressure decreased from 18 to 14, and the number of pre-operative AGMs. So patient was on 2 anti-glaucoma medications, and post-operatively he was off medications. So that is
How
what
does the procedure compare with the other mixed procedures?
Sir, efficacy of bang is equivalent to other mixed procedure like KDB, and this is very inexpensive and it can be done without the use of any special instruments or any equipment.
So it's just a few $100s cheaper.
Yes, so this is nothing, this is just
No
an
other difference
extra 24 gauge needle we require for the procedure. Yes, yes, yes. Sir, because most people do the other way because I feel that before doing phaco, there is only one entry into the anterior chamber. So the anterior chamber is more stable. And we can, if there is any hyphema or any trabecular meshwork remnants are there, so while doing the phaco, that are easily removed. So yeah, it works better, I feel, when we do the bang first.
And generally, how long would the effect last? I mean,
Yeah, we will be publishing a study from PGI in the coming time. So we have a 1-year follow-up. So the results are very good. In that study, the number of pre-operative AGMs decreased from 2.8 to 0.6. So the results are very good over the 1 year that
2.6.
0.6, yes. So the decrease in
Do
the
you have any
anti-glaucoma.
comparison with somebody who's just had a cataract surgery and not had any MIGS?
So we don't have that
But
study,
any,
but
let's say from the international data?
yes, sir, because the MIGS will work more than plain cataract, definitely, sir. So the reduction in
If you can add evidence to that, it
yes,
will be
yes, yes.
better.
Generally,
yes.
how long do these last, mix, all mix, generally?
At least 2 to 5 years. If the initial time period is good, if initially they have worked well, then they'll last for at least 5 years, ma'am. So we can
5
delay
years.
the trabeculectomy, and the ocular surface which the patients are not tolerating the medicines, that gets very better. So even our trab works better later on. Yes, yes, ma'am.
Thank you.
Okay.
Thank
Do you tilt the head and you position of operating microscope?
Yes, we do both, sir. We around 30 to 35 degree microscope is tilted, and we move the patient's head in the opposite direction.
Okay.
So around 70 degrees, so that we get an en-face view of the angle. So the angle is en-face to the surgeon.
That means you have to make a lot of adjustment
Yes, yes.
for doing this, then again to switching back to
Yes,
cataract.
yes, yes. It takes 10 minutes extra than phacoemulsification because the adjustment time is more, yeah.
And do you think it can replace MIGS as such?
Sir, in a developing country like India, yes. I think this will be the future coming, yeah, definitely. Because
If the results are equivalent, why not in the more economically better countries also?
so it will come because, yeah, definitely. Because it's a new technique and it's coming up very well.
Thank you.
Thank you, sir. Thank you.
Then we move on the next stop by the great entertainer of Indian ophthalmics, Dr. Mohan Rajan.
Thank you.
Should I reduce the voice?
No, 1 minute. Yeah, it's okay. I think yeah, there are 3 types of intermittent cataract: type 1, type 2, type 3. The type 1 is the more dangerous because Argentina flaxan, as you know, can occur because the interlenticular pressure is very high. There is a component, there are 4 components: pressure underneath the anterior capsule and pressure in front of the posterior capsule as well, which and the nucleus is also bulky. So what I'm trying to demonstrate in this technique is, I'm just putting viscoelastic there, putting blue Rex, that is the trypan blue, and then I'm introducing a 27 gauge needle. Can you see how beautifully it aspirates? The cortex, the liquid cortex which is there, because of that the interlenticular pressure is reduced. Again, I'm using a 26 gauge needle in this case. You can use a 26 or a 27, and you can see here I'm just making a small nick there and aspirating. It's a very easy technique. Of course, I have developed the punctorexis that involves a little bit of a learning curve. Very easy technique, everybody can do this, and you can see that the entire pressure which is there in the anterior compartment is taken care of. That is the compartment number 1, which is taken care of, and most of the times you can get away with the beautiful rexes without producing Argentina flax sign, and that is the main idea, because in 2 minutes, if you want to give some good take-home message, this is a very simple, doable technique by one and all. So you can see that once you do that, there is no pressure and there is no nucleus coming forward, which normally happens in a type 1 intermittent cataract. It comes forward and you can see that beautiful rexes, you can do that. Otherwise, you need to aim for a small rexes, otherwise you can have a good rexes here, good, fairly big rexes. The take-home message is very, very simple. A nick in time, aspirate with a 26, 27 gauge needle, take care of the, and use a good high molecular weight viscoelastic, and you can go ahead with the intermittent cataracts without any problem. Thank you very much.
Excellent.
Thank you, Mohan.
Thank you.
Can you specify which type of cases it will not work? You showed the cases.
No,
where
in this
it-
case
it
also, the
aspirates
type
well.
1, see, there are, as I told you, there are 3 types of cataracts, mature cataracts. Type 1, type 2, and type 3. The type 1 only is, there's a lot of pressure inside, and there's a positive vitreous pressure as well, and they are more likely to get Argentina flax sign. Type 2, less chance of getting Argentina flax sign, maybe less than 30%. Type 3 is the hypermature sclerotic type of cataract, calcified, you don't get an Argentina flax sign. Okay? So type 1, this will work about 50-60% of the time. In punctorexis, it will work. Only thing is punctorexis you need to do with the phaco probe, go down, that involves a little bit of learning curve. That will work about 70-80% in my study, 80% of the time. But if you want 100% working, then I do the femtorexis. Because I got catalyst, you also have access to catalyst, I'm just telling you. Yeah,
That's also not 100%.
it is 100%, sir. In my,
You would still get an occasional radial extension because of
because
incomplete.
the problem is when you do the catalyst, sir, you have to look for skip areas in a mature cataract. Don't try to pull it up because many times it's not a free floating. The skip areas you need to go in and find out, use a trypan blue, stain it and nicely use a good viscoelastic and then you can find out. I have not had a single case of a flap going off. Yes, Sugato.
I'm using this technique for last 7 years. Only difference is that I keep the bevel down. That gives more area of the needle exposed to the fluid to be sucked. If the bevel is up, is opposed to the capsule. If the bevel is down, you are getting more.
It's a very good point. Very good point.
Works very well. And other thing which juniors should do after sucking it out, just press with the needle the nucleus.
Absolutely.
Down.
Yes.
That frees up the posterior pockets as well. But still I do a smaller rexis because it doesn't free up the peripheral intubations.
Yes.
It works in the intubation cataracts. In the Morganian, one leak and the fluid
Will leak out.
doesn't require, but in intubations it works very well. But still I do a smaller rexis after that, break the peripheral intubations and then do a bigger rexis.
Bigger, double rexis.
Double rexis, but initially with the puncture error.
Absolutely. I think it's a good point. What Sugato has rightly mentioned, which I forgot to mention, is that when you go with the needle, you can go bevel up, bevel down, probably it's better. We have not done that. I go bevel sideways as well, doesn't matter. But at the same time, what you do is just depress the nucleus a little down. Because what happens is in intermittent cataracts, because I've done a lot of study for my puncturexis, I got the Sante Vision Award also for that, and also the APSCRS Video Award. So if you do that, what will happen is, there is a pressure in front of the posterior capsule, and there's also a positive vitreous pressure, which pushes the nucleus as soon as you puncture.
Why do you get the positive vitreous pressure with these?
Because of this intermittent lens, sir. Because it's occupying so much of space, these lenses are all much bigger for the eye. It's crowding the angle as well. So that is the biggest problem we have.
Thank you.
Yeah, thank you.
Let's go on to the next presentation.
Next presenter is Dr. Sangeet Mittal. He is going to present on 360-degree giant retinoids with close funnel detachment.
And the biggest tip
60
is
years
never
male
say never
presented with
again.
decrease of
Yeah, please.
his visual acuity was perception of light only with inaccurate projection of rays. On examination, he had total hyphema with vitreous hemorrhage. B scan revealed closed funnel retinal detachment. And after clearing the vitreous hemorrhage, 360-degree giant retinal tear with closed funnel retinal detachment and crumpled up retina was seen. Subretinal traction was identified and subretinal bands were removed. In closed funnel detachment, there is usually a circular membrane which causes circumferential traction. If the membrane is crumpled up, this membrane extends up to the edge of torn retina. Preretinal membranes were removed slowly along the edge of torn retina. Once all the membranes were removed, the optic nerve head was located and PFCL was used to open the funnel and flatten the retina. Tano's membrane scraper was used to stretch the retina and remove any retinal folds. 360-degree barrage endolaser retinopexy was done. 8 to 10 rows were given all around the retina. Direct PFCL silicone oil exchange was performed. Sutureless closure of sclerotomies was done. Postoperatively, retina was attached and vision had improved.
So the biggest tip is never say never again.
Yeah, that was very good. Do you think this was excellent? But do you think when you shift from PFCL to air, you can get a slippage. Would you rather go directly to oil?
Yeah, I will prefer to go in such large tiers directly to oil because there are increased chances of slippage with if you go from PFCL to
But I
air.
think here you showed air, right?
No, I use direct only.
Direct. Yes.
Yes, sir.
Yes. PFCL to oil. And do you use a 5,000 oil or a heavy oil? Or
No, 1300 1300 only. And the oil was removed 3 months later.
Okay. Is there any tips to prognosis when you take up a case like this?
Yeah,
Is there
prognosis
something
is
which
extremely poor. One thing is like the vision recovery, you never know what is going to happen. Another thing is prolonged hypotony in these cases, and that also needs to be explained to the patient. But that's why I said, but never say never again.
Have you left PFCL anytime just so that there is no disturbance and then come back later after 2 to 4 weeks and change to oil?
Yeah, that could be done, but if you can do it on the first sitting, you can avoid the surgery later on.
But sometimes it can, when you're trying to change the from PFCL to oil, you might have a problem.
Yeah.
And then you can't reverse the problem sometimes.
Yes.
So a layperson question, why does the hypotony occur?
So most of these cases are associated trauma cases. This was one of them, and there is many a time ciliary body detachment associated with it leads to hypotony.
Or if it's a long-standing case, then also there's a shutdown. Yeah, in literature supports up to 3 weeks, but I have seen no problem even up to 6 weeks or 8 weeks. Nothing happens. But definitely 4 weeks there is no problem.
Thank you, sir.
Very good video. Thanks.
And now we'll move on to again a retinal topic. Dr. Vibhuti V. Kashyap is going to speak on submacular TPA, dive deeper, dive safer.
Submacular TPA. Dive deeper, dive safer. Submacular bleed is a sight-threatening condition, treated mostly with pneumatic displacement. Including TPA in its management improves outcome by increasing speed of clot dissolution, thereby reducing heme-induced RPE damage. Outcome of intravitreal injections of TPA is often unpredictable due to multifactorial causes. Hence, the best route of treatment is submacular. The concern with submacular delivery of the drug is a controlled subretinal microdose delivery to prevent retinal rips. To combat this concern, I employ a microdose injector that uses this 38 gauge cannula which fits on the injector. The injector can be connected to silicon oil plunger through which we can shift the control of speed of injection to the foot pedal instead of a manual control, thereby combating the concern. With the injection pressure reduced to about 10 to 16 mm, the speed of injection with full throttle on the foot pedal is visible by the rate of wetting of the towel in this video. This video is an example of employing this technique to treat a case of post-traumatic vitreous hemorrhage with submacular bleed. Here, after a core and a peripheral vitrectomy and a 360-degree laser circlage, the macula was pierced with 38 gauge cannula and with full throttle of foot pedal, a controlled subretinal bubble of the drug was achieved, followed by fluid air exchange and C3F8 gas injection. At 3rd week post-op, the macula was completely cleared of the bleed. Pre-op OCT that demonstrated a subretinal bleed accumulation with a BCVA of finger counting close to face improved to a near normal anatomical restoration with improvement of vision to 5/60. Thank you.
That was an unbelievable anatomical result.
Sir, actually, if you look closely, there was a large amount of ISOS discontinuity that also happened. So I won't call it that's why I call it near normal. It was not actually absolutely normal.
For cataract surgeons, this is unbelievable.
60 years.
Yeah, for cataract surgeons, everything we do should be unbelievable. This was very good. Did you also inject some air under?
No, ma'am.
No, it was just TPA.
Yes, ma'am. The entire idea of this video was to just show two things. That what I believe in my practice, after going through all the published literatures on TPA, is that TPA acts magnificently in subretinal bleeds, but somehow there have always been logics given to combat that use based on pneumatic displacement alone, sometimes intravitreal TPA, only because of two factors. Firstly, a presumably steep learning curve of the submacular injections because it's a manual delivery. You may end up causing a rip or a hole. And second is the cost factor. So these are what I showed are all ETUable instruments which can be reused, and the total cost of TPA injection that it costed me with this mechanism was 9.5 thousand rupees, which is hardly peanuts in comparison to what we usually inject in intravitreal anti-VEGFs. And secondly, this mechanism, it converts the manual control in the hand to a foot pedal, which also does not need a learning curve of a slow, gradual foot pedal. The rate of wetting of the towel that I showed was actually with a full throttle of foot pedal. So there is absolutely no learning curve. You just have to pierce it, make it just a bit horizontal, and give a full throttle, and it will still, make a beautiful, slow-forming retinal bubble. And then if we adapt this, then there's a very easy transition, and a threshold is very much reduced as to when, where, how will you treat a submacular bleed. I have cases, I have an instruction course going on right across the hall about treating an old submacular bleed also with this condition. So I would say thresholds will be reduced.
Okay, so this vitrectomy was done because there was an associated another condition also, or just for the hemorrhage, only for the hemorrhage, submacular hemorrhage?
No, no, ma'am. Vitreous hemorrhage, as well as my threshold for vitreous hemorrhage in a post-traumatic case is low, because often what I have seen is while waiting, there may be breaks that have not given way, so we may end up complicating a retinal case. So even if there was not a submacular bleed, I would have probably intervened earlier than what I intervene usually for a PVD-induced spontaneous bleed or a diabetic, not a diabetic bleed, vasculitis bleed. I would have probably waited, but in traumatic cases I intervene early, even if there is even if there is no
Is there a particular number of days before which you will decide that I will go submacular rather than I can just give pneumopexy, inject gas with maybe intravitreal TPA, which is less invasive, much less invasive, and prone position? Is there a number of days you decide?
Ma'am, that is what, after going through the literature, the entire
Not the literature. Let's talk about your practice.
Ma'am, my practice is very, very, very low threshold for a PPV in such cases, because I have a zero learning curve with this treatment modality. So it gives me 100% results on the table. I have done approximately 100 cases, and all of them have resolved on table.
What are the possible negatives of this technique?
Too many.
Not in your hands, but
no, you can have
sir, one of the causes is, I mean, you have to be very, very gross with the movements, and then you may injure the underlying choroid, but that is where you need to be a VR surgeon first and judge as to where the macular elevation is the highest, or if there is any space between the choroid and the retina, and then you go inside and just make it a bit horizontal and inject. So we can avoid that kind of thing, but that is the remotest of thing that I can think of that you may. But you have to be very, very gross with your movements to actually hit the choroid, because the soft tip is also a soft tip at the end of the day. So it's pretty safe.
Even just doing a vitrectomy has the risks of retinal detachment, and just doing vitrectomy is enough. But it's an excellent technique.
Sure.
Thank you.
Thank you, ma'am.
I'm no cataract surgeon, but very curious to know. You are using full throttle and very slow delivery.
Yes.
So you have to hold the needle in place for longer time, and slightest movement can extend the hair. So, and chances of leaking out of the injection to the vitreous. That's what I'm curious about. And the other thing is, where exactly do you normally inject? Is it in the bleed or in the lower portion of the bleed, giving some space for the bleed to come down?
So answering your second question first, the injection is, my preferred place is injecting the submacular injection just superior to the bleed. At an area of an elevation, so that I have space of the cleavage plane to inject the medication, and it forms a gradual bubble. The bubble formation is very slow, but it takes approximately 10 to 12 seconds. That is not a very long time for you to keep your hand stable. Of course, once you're going, you will attempt this case only when you are a VR surgeon. So that stability while an ILM peeling is always there in a VR surgeon's hand. So yes, coming to your point, if you go inside and if you start moving, of course it's going to cause a rip, but that is the entire point. Like your hand has to be stable. You have to be a VR surgeon. But if you keep your hand stable for like 10, 12 seconds, it's not going to cause any problem.
It's not very difficult when you know the stakes are high. That's not, I think, difficult.
Thank you very much.
So 38
Yeah,
gauge.
it's available up to from 38 to 42. Yes, of course. The thinner,
So
the better.
anything lesser than 35 will do, sir. Because anything below 35 is cell sealable.
Creating the space below the bleed, then from gravity, chance of settling down is more or no?
See, then we depend on the gas which has been injected and prone positioning. So once the TPA has lysed the blood and now patient is face down, the gas goes up and spreads it to the periphery. Our idea is to displace it to the periphery, not necessarily inferiorly, but anywhere except in the center, which happens very fast.
Thank you.
Thank you.
So let's go on to the next one.
So from vitreous, we move on to cornea, back to vitreous. Dr. Nidhi Gadkar is going to present sandwich keratoplasty to combat positive vesicule pressure.
Sandwich keratoplasty. This technique has been previously described for pediatric keratoplasties. But what to do in a therapeutic keratoplasty where anterior chamber needs to be cleared of exudates and inflammatory membranes? Positive pressure in full thickness keratoplasties can cause multiple complications. Positive pressure can be noticed sometimes from the point of entry into the anterior chamber in spite of taking proper preoperative and intraoperative measures. This is more possible in young patients and larger grafts. Tip is to not incise the full rim of the host and leave a hinge. Any anterior chamber manipulations can be done by lifting the host button by the hinge. This gives a safety window of placing the tissue back in case of positive pressure. In cases having risk of impending lens expulsion, a sandwich keratoplasty can be done. This technique gives immediate anterior chamber formation, prevents sudden decompression, and leaves no time of open to sky, thus preventing all the complications associated with an open sky surgery. In this case, right from the trephination, there is a positive pressure. The host button after cutting is sutured back at 4 cardinal points, and after placing viscoelastic over it, it is sandwiched between the donor corneal button above and the iris lens complex below. The donor is then sutured at 4 different cardinal points. The sutures of the host are then cut and it is slowly slid out of the sandwich, and the anterior chamber is formed by viscoelastic. Viscoelastic placement between the donor graft and the host corneal button minimizes endothelial damage to the donor graft. This technique is safe and repeatable in cases of excessive positive pressure when donor is already cut and vitrectomy is not possible. Thank you.
So what is the difference in, say, endothelial counts if you don't do a sandwich technique and if you do a sandwich technique? Do you lose endothelium?
So definitely there will be some endothelial loss, but here we are trying to save the lens and prevent the expulsion. So that is more important. In large grafts, even if the graft fails, but the lens is intact, we have a second chance of giving vision. But if there is an auto expulsion of the lens and an expulsive, then we have lost the game there itself.
So this is if the positive vitreous pressure persists in spite of all other measures taken, right? You would have
yeah. This is after I have done whatever is required. Preoperative mannitol, speculum is loose, there's a Fleringa ring, everything has been done. Even after that, if it persists and I have not made a port before I have opened up the graft, the host, then that's a problem.
Why not go through pars plana and maybe put in a vitrectomy and do some reduction?
Once we have opened the globe, sir, then it's difficult to go into the vitreous. Then maybe we'll have to suture the whole graft again and then make a port or do a vitrectomy. But here the time is quite less, so this is much quicker versus doing a vitrectomy.
So this is an emergency measure.
This is an emergency.
On the table you decide.
Okay. There will be endothelial loss.
When you try to pull it out, because there will be some endothelial, so you don't want any sort of trauma to the endothelium, especially when you're doing a PK like this, you know.
Yes, sir.
Yeah,
So
that's the only concern.
this is more for larger therapeutic grafts that I'm talking about. In pediatric cases,
Which are in any case doomed to
Anyway,
failure.
okay,
This
that's
is,
fine.
this is not actually an optical only.
Yeah.
Thank you.
Thank you. And we now move on to the next speaker, Dr. Saura Kamal Datta, he's going to speak on autologous tenon patch graft for the treatment of minor traumatic corneal perforations.
Good afternoon, everyone. I am Dr. Saura Kamal. Today we are going to talk about autologous tenon patch graft for treatment of minor corneal perforations. So, a 25 years old male came to us with a history of trauma in the left eye, and we could see a intact foreign body in the 4 o'clock position of the cornea. The rest of the findings were normal. The AC was well formed. The iris was not injured. The other eye was completely normal. So we can see now the picture of the cornea. In the picture of the cornea, we can see that this is the slit lamp photo and a 3 into 5 mm corneal perforation with in the 4 o'clock position with the foreign body can be seen. So we put up the case in the OT and we put up for the repair. Once the foreign body is removed, we can see there is a fish mouthing, and this cannot be closed using sutures. So what to do? So we put a tenon's patch from the same eye and we suture it in that position. And after that we put a BCL over it and we'll follow up the patient. So what did we gave moxifloxacin, dexamethasone, carboxymin cellulose and atropine sulfate and follow up the patient. We can see after 1 month the graft is well taken up, the bandage is in situ, and after 3 months there is well assimilation of the graft and the bandage contact lens was removed. So after 3 months the vision was also improved to 612. So we can conclude that the tenon's patch graft is a cheap, convenient and inexpensive method for treatment of minor corneal perforations. Thank you.
Is this a new technique or is it already been in practice?
It's already been practiced, ma'am, but generally we use glue or something, but in peripheral areas where these are not available, we can use tenon's patch graft. In emergency cases in middle of the night, then tenon's patch graft helps.
So, what would you specify as the indications? Where would you not do it and where would you do it?
In case of small graft,
How do you define that small?
3 mm. Below 3 mm we can use glue only, fibrin glue. But if it is more than 3 mm in size, then there is gapping that cannot be sealed using sutures. Then we can.
You're talking about perforations due to what causes?
For non-infective foreign body, like in this welders and all. Non-infective iron particles foreign bodies.
So why not suture it?
Yeah, it's not, if it is not, if there is a big fish mouthing and if we give sutures, then there will be huge astigmatism. So to prevent that, we can give tenon's patch graft.
Okay.
And absence of.
And why did you choose tenons only and not something else? Do you think you could have used an MD?
Because it was an emergency case, so we didn't have the option of taking other like amniotic membrane graft we can take or something other. So, but in that cases that we had only one option in that day.
And where do you get that tenons from? From an eye bank eye, right?
Yes.
So you could also have a amniotic membrane
autologous tenon.
Is the middle.
This is not autologous.
It's an emergency case in the middle of the night, so we could not get tenon's graft in the position. So we used that, amniotic membrane we could not get at that time. So we used tenons only.
From the
same
eye bank?
No.
Autologous.
Autologous tenon's graft.
Yes, that's
it's autologous.
I missed that.
I was saying autologous. He said no, it's from. Yeah.
Autologous.
It has to be autologous. Yes. Why choose anything else? Yeah, but what would be the specific indication? Say, let's say patient of rheumatoid or collagen disease. Yeah. Yeah, but small linear traumatic ones, you would much rather be suturing unless there's a loss of tissue.
Sometimes we're not able to suture it, sir. The problem is.
Yeah. Only those. So that's what I want him to specify.
Absolutely, because very difficult. Fish mouthing will be there, irregular tears will be there.
Or you're supporting your completers.
Huh?
You're supporting your completers.
For me, it's not a competition, sir.
He's so gracious and
no.
You know, there's another obvious reason behind.
I think younger person should get.
Yes, that's the graciousness.
10-0 Thilon. Interrupted sutures in taking all the quadrants.
Thank you.
Thanks.
Thank you very much. And we now move on to from cornea to the IOL. Dr. Sugato Paul, he's going to speak on IOL twist sign and releasing a stuck haptics from the cartridge. Dr. Sugato Paul.
In this video, I will be showing IOL
one
twist
second.
sign as a possible
Can you
predictor
stop
of
the-
stuck haptic and how to rescue it.
Yeah.
Normally,
So can I speak? Because when I recorded and uploaded, I had an operation, so my voice was not good. So I had to use artificial
I'll
things,
start.
so I'll speak.
I'll start from the beginning.
If you can lower the volume, please. Yeah.
It's closer.
So good morning. So here I am describing IOL twist sign, which is not being described before. IOL normally comes out of the cartridge in uniplanar way, and we place it. Now in this case, I did a phaco, and I'm inserting the IOL, and you notice the twist in the IOL, which I didn't realize at that time. When I audited my video, I noticed that. You notice the twist of the IOL. I delivered it. I was not knowing that, and the cartridge broke. No, sorry, the lens haptic broke, and we had to explain that IOL because the haptic has broke. So my theory is whenever there is a twist in the IOL being delivered, you have to be aware that there is something going wrong. Now in this case, I was aware of that, and you notice the twist again, and here is the twist. So I was thinking, okay, the haptic might be stuck, and I was right. I didn't go ahead and deliver the haptic because it would have broken again. So I hold my breath. I was doing hydroimplantation. I exchanged with a visco, formed the AC, took the plunger out gently, and then to release the haptic from the plunger, gave a nick with the side port blade. Now my plunger is protruding out from the nick, and my haptics is loose, so that I can release the haptic from the cartridge and I can put it back. This has been described before, but in no textbook IOL twist sign has been described. And these are the two tips I wanted to share in 2 minutes. Thank you. So basically my theory is if you are holding someone's hands and pushing him forward, there will be a twist. But if you are pushing without holding, if you are pushing someone, the push will be straight. So IOL should go straight ahead without any twist. If there is any twist while delivering the IOL, you have to be cautious because most of the time we depend on our assistant to load the lens. So you have to be cautious that there is something wrong and don't deliver the IOL in haste in those situations.
Can I add something, sir?
Sure, sir.
A beautiful video, but I don't know whether you've seen my IOL acrobatics video.
Yes.
Which is there, everything is there, all the IOL complications will be there. But I'm just telling you, whenever you inject, there's a message I want to give everybody. Whenever you inject, if you feel a lot of resistance is there, very tight it is, don't inject, come out. Maybe reload. Sometimes you can have this preloaded lenses, you can have that as well.
Yes.
And I have described this technique called ocular episotomy, it's called. And this 11 blade, what you use to open up the cartridge. Last year, I think, presented to Cochin. I was unfortunately not there in that session. But just open up the cartridge. Because don't try to pull it out, as Sugato was rightly saying. Don't try to pull it out, it will fracture. The lens, the haptic will get, and you will have to explant the lens. You have to extend the incision or cut the lens and explant. But if you wait for, be a little patient and wait for it, and because there is a very little space, the haptic gets caught between, especially the green injectors, no? The green injectors, the medicinal injectors, this can happen.
True.
Dr. Kumar?
Kumar?
It happens most in the hydrophobic because they are very soft lens, and if you don't realize if there is a twist, that means their haptic is caught somewhere. So you have to be gentle and re-examine, and if you can, because I was doing hydroimplant, you cannot, but if you are doing under visco, just try to pull the cartridge away and see. But the best thing is probably to examine the lens under the microscope. But because you are doing hydroimplantation and your assistant is loading is not always possible. But it breaks mostly in hydrophobic.
So I don't think there can be a take-home message saying that every twist will have a stuck haptic.
No.
That
but
should
twist,
not be the take-home
but
message.
if there is a twist,
There is a possibility.
There is a
Yeah,
possibility.
so that should be
because I have audited 3 of my broken haptics and there was a twist.
Yeah.
And also in this case where it didn't break, actually I recognize that there was a twist as well.
Yeah. So I think it is also IOL specific, the IOL design, IOL material and how you have loaded. So it cannot be a blanket message, that's what Kumar says, and very rightly said. And very simple method is a push and pull technique. So whenever you are pushing the IOL, you release your plunger, and if the IOL comes back, that means it is stuck somewhere. There is a possibility. Again, it is not always, but this is also a possibility. So if you keep on injecting the IOL, and if the first septic comes out, and if you release the foot and the IOL comes back, that means it is stuck somewhere. So that is also a very easy way of knowing whether it is stuck in the cartridge along with the plunger or not. Excellent. Any more questions?
Thank you.
Next.
Thank you.
Thank you.
Yeah. I think the message is very clear. If you feel resistance, you have to come back. You have to push back it.
So a combination of signs should warn you that there is a possibility.
So from all these, we go to the LASIK now. Dr. Jain Khatib. He is going to speak on Khatib LASIK globe stabilizer. Dr. Khatib, please.
We all know LASIK is one of the most visually gratifying procedures, and yet there are a fraction of patients unhappy after LASIK. The most common reasons being dry eyes and induced higher order aberrations, namely spherical aberration and coma. But with topography guided LASIK, these aberrations now are also extremely rare. However, sometimes in spite of doing topo guided LASIK, high aberrations are induced during surgery, and there could be multiple factors for this. It could be due to accidental flap ablations, which is more so seen in hyperopic and astigmatic treatments. Sometimes the laser beam is not focused properly on the surface, due to which the treatment gets under or overcorrected. Other times there is movement of the eye during ablation, and the lag of the eye tracker and cosine effect of the laser can lead to induction of coma. To overcome these problems, I have made a simple and yet effective instrument, the Khatib LASIK Globe Stabilizer, which, as the name suggests, stabilizes the eye during LASIK. It has two main parts, a head and a handle. The head, which fixes on the eye, has an opaque surface which protects the retracted flap and hinge, and multiple blunt teeth on the lower side to fixate the globe during ablation. The handle is specifically designed with a backward angulation so that it won't interfere with the eye tracker which comes down during the procedure. This is how it works. Once the flap is retracted, the eye is focused so that the two red spots are slightly separated. Then the instrument is applied with the flap protector over the hinge, and it is pressed downwards until these two focus spots join in the center of the pupil. Now it is in perfect position and held like this until the ablation is over. This is another case of a hyperopic treatment where you can see the instrument is really protecting the ablation from happening over the flap and hinge area. This is a photo of my instrument after multiple uses. You can see this crater. It demonstrates how much of laser has already taken place on the instrument, which would have otherwise gone onto the flap.
You want to speak first? Go ahead.
Decentered ablations can happen in technology which looks only at the pupil and the XY tracking. If your system has a 6-dimensional eye tracking, it's never an issue. So you can never have a decentered ablation. We used to have it in '99, and after that I've never seen it. As far as flap protection is concerned, it was also an issue many, many years back. That is when Banerjee had introduced a small Beck sponge which was called a hinge protector. Again, it's not today's era necessary because new laser machines have a line on your screen and it will tell you whether you are ablating the flap or not ablating the flap. So you really don't need in new era machines to protect your hinge at all. And as far as the stability of the eye is concerned and the cosine effect is concerned, again, it was old. So when we had the old Bosch & Lomb machine, that time the cosine effect we didn't know existed. After '97, after 5 years, scientifically we came to know that a cosine effect exists, and that was now automatically compensated by the technology. So, and again, we can operate today's in new machine technology. Patients with nystagmus can undergo LASIK without any issue because the machine is tracking. So if you have nowadays, there is a 7th dimensional tracking, forget 6, and that's time. And that also helps you protect. So it's a brilliant idea, very good. but it may be useful in older LASIK technologies. In new era, I don't think this will be that useful.
So just to answer those questions, so what we are not debating about the fact that the tracking is very good. What I am talking about is the small lag that the machine takes to track when the eye is moving fast. So this generally doesn't, it's not going to affect the visual acuity per se, but definitely is inducing some amount of aberrations because the laser is not moving along with the eye simultaneously. It's moving after a fraction of a second. Second thing is about the hinge protection. Definitely a Merocil sponge works very well. But if you've got a hinge width of about 5 to 5.5 millimeters, sometimes the Merocil sponge itself doesn't cover the edges, the side edges of the flap. So this device basically, is not doing something that is, going to drastically or dramatically improve the vision. But what it is doing is it is doing something all in one. That is, it is stabilizing, the eye is not moving, it is focusing, and the complete hinge is getting protected. So I didn't have time, I didn't show my results, but I have about 30 eyes where I've done one eye with and the other eye without. And the coma effect is actually shown lower in this as compared to those, especially in those patients who have moved the eyes, which I'm going to be publishing soon.
Yeah, Dr. Zain, so I would slightly differ, and I would also go ahead with what Kumar said. If it is a nystagmus, I would definitely want to stabilize the eye myself manually. And that is where I would try and use certain kind of gadgets. But understand when you are actually performing the examer laser, the patient is also slightly moving, you are also trying to press. And there are multiple variable factors which I would say that will add more aberrations. So a pressure which is not going to be uniform, the eye is also slightly moving, there might be an additive effect or there might be a counter effect. So it is best left that with the modern lasers, just leave it like that. But definitely use it for nystagmus or certain other situations. Excellent.
It's available with Epsilon, sir.
I think the decentered ablation is not any more common now.
Yeah.
Of course, the decenter flap can occur, especially with a mechanical device. So there it can be helpful.
Thank you.
Thank you.
So let's go on to the next one.
Now we move to the next topic by Dr. Bhavesh Saha. Challenges in the management of anterior persistent fetal vasculature syndrome. Dr. Bhavesh Saha.
Good afternoon, everyone.
Persistent fetal vasculature has a spectrum of presentations, ranging from anterior findings to posterior findings. Anterior PFV syndrome arise with mostly tunica vasculosa changes. Anterior persistent fetal vasculature rarely isolated, and less destructive than posterior PFV, resulting in better surgical outcomes and visual results. Diagnostic challenges in anterior FVs are misdiagnosed as a congenital cataract. As there is no fibrovascular stock, the B-scan ultrasonography shows normal scan. Doppler-associated ultrasonography report also indicate normal vasculature in posterior segment. Mostly diagnosed intraoperative. Intraoperative challenges are to secure bleeding and removal of thick fibrovascular membrane. Bleeding from remnant of anterior vasculature is being secured by endodiathermy. It is very difficult to remove the thick fibrovascular membrane from anterior and posterior capsule. Sometimes pneumatic vitrectomy cutter and even micro scissor fail to remove the thick fibrovascular membrane. Here we used endodiathermy to coagulate and remove the thick posterior fibrovascular membrane in a circular fashion. Lens was implanted into VEG. To conclude, isolated anterior persistent fetal vasculature is rare and misdiagnosed due to lack of posterior finding. Endodiathermy can be used both to secure the bleeding and removal of fibrovascular membrane. Thank you.
So who was narrating this?
Yes, sir.
Who was
Sir,
speaking?
It is the computer generated voice.
Ah, okay. Because it had a huge accent, so I was
So
wondering.
the only challenge, as I understood, is bleeding. And
The actual challenge is whenever we see a case of, suspect a case of PHPV, we generally thought about the posterior part only. And it is in very rare cases, only few cases reported that is the anterior part, although posterior part already regressed, but remnant of anterior part can lead to bleeding and if even diagnostic difficulty because ultrasound shows normal, Doppler show normal vasculature, that's why. And second is bleeding.
Is it a smaller globe compared to other eye?
No, in this case it was not, but in reported cases there is a microophthalmia and elongated ciliary body also.
But in this
case there is no microophthalmia.
So is it relatively rare, anterior persistent?
Yes, it is rare.
Thank you.
Yeah.
Sometimes the retina, this thing is attached to it, to the posterior, sometimes PHPV, no?
No, here the posterior segment is not involved at all.
Here,
in this case,
generally,
yeah, of course.
PHPVs, yeah.
It is mixed type is common and posterior is very common, but anterior part, as I have shown in this case, it is very rare. It is only isolated, and it was only isolated anterior part of PHPV.
So there's no attachment?
No.
No, that's what he said.
So we go on to the next one.
Thank you.
So the next we have Dr. Bhupesh Singh. He is going to present vitrected assessed anterior capsular rhexis in the adult intumescent cataract. So there is one more way to do the rhexis.
Play, please. So this technique is the vitrector assisted intercapsular rhexis in adult intumescent cataract, and a lot of techniques have been described, and Dr. Mohan Rajan sir has described puncture-rhexis, which was popular at one time. But although some limitation was there, and we tried to overcome those limitations with the vitrector. So intumescent cataracts has a problem with the high intralenticular pressure, which creates the problem with the rhexis. We all are fan of Argentina, but no one likes Argentinian flag sign.
Correct.
So we described this technique in IGO, and this was the advantage of this technique is that you don't have to go through the main incision. You can do the use the vitrector from the side port, so you're not decompressing the antechamber. And other is that with the vitrector, just see the opening. So opening is always linear. So linear opening you can easily convert in a rhexis. With puncture-rhexis, the opening is always circular. So circular, it's difficult to make the rhexis, and with the rhexis forceps, you can convert it in a nice, desirable size rhexis. And the visco is not coming out. With phaco, when you use phaco machine, phaco handpiece, it sucks the viscoelastic and decompress antechamber, which can cause the further extension of rhexis. But with the vitrector, you are not using any irrigation cannula. So under viscoelastic, just do the vitrector. The cut rate is 300 and the vacuum is 500. So it is very controlled and can be used very comfortably in all cases of intumescent cataract. Thank you. Thank you so much.
Something similar to what Dr. Mohan Rajan presented.
I think you should be sitting here more.
No.
And you can forgo your competitive.
No, that's not a problem. No, I tried this. The only problem when compared to the puncture-rhexis, I'm using a phaco needle, a straight needle beveled down, okay? If I'm using a 15 degree or otherwise a 0 degree, you go straight down because you punch the anterior capsule, same time you debulk because you're giving some phaco as well.
Yeah.
You're debulking the nucleus and pushing the nucleus back. So within a millisecond, both the anterior and the posterior compartments get decompressed very fast. So you don't allow the time for the nucleus to come forward and produce the Argentina flag sign. The problem with the vitrector is, in my experience at least, I'm sure you can say better, tell better, but I'm just telling you, because vitrector you do not know, because you saw that there's a linear tear there.
Yes, it's always
linear tears, no, there's a possibility of going tuck into the Argentina flag sign. But if you have a circular, it is not actually circular in puncture-rhexis. It is circular and there will be a small tag there. If you notice my videos, there will be a small tag there. And the circular is thing, the tag you can just hold it to the capsular forceps and go on. And here, because you don't have the control like phaco punch, that's what my experience.
Yes, Kumar. Give a mic to him.
Very nice video, but I was just thinking, do you have any viscoelastic in the anterior chamber? And what are your settings for the vitrectomy?
So vitrector setting is 300 cuts per second and vacuum is 500. And we use viscoelastic. So the difference between puncture-access is this, that you are going from the side port, not from the main port, that you have to make with the phaco. Other thing, when you start the phaco, you are giving fluid in the anterior chamber, so which will displace or aspirate the visco. But in vitrector, you don't use any irrigation cannula. So visco will be there, so it will avoid the further extension of the rhexis. So that is the difference.
So what kind of visco?
Yeah.
High viscosity. Yeah.
So yeah.
Yeah.
See, no viscosity. Yeah.
Not a dispersive one, yeah.
Yes.
Though you said linear, actually your cut was semicircular, and that is probably protective, because once it is semicircular,
sort of linear,
the force distribution becomes unequal and chance of running out is less.
It's like a leaf.
Linear cut,
leaf.
It will
rapidly
can
expand.
Yes.
True.
Nice.
Okay.
Thank you, sir.
Thank
Thanks so
you.
much.
Thank you very much. And now we move on to the next talk by Dr. Debashish Datta, a panacea for double dialysis.
Good afternoon, everybody. Yes, how does it start?
It's not moving. Yes.
I think I need to talk. Can you have the mic?
You have a voice there?
Can you start it from the beginning, please? This is a case of double dialysis whereby you have this iris zonular dialysis and also iritodialysis simultaneously, one after the other. Literature review did not reveal any such case. So I thought of this, doing it in this way. Pocket, then go inside through the from the iris outside inwards, bring it out through railroad, out through the eyelet of an segment CTR, put it back by railroad from inside out, and bring it out in the area of ciliary sulcus, and bring the entire complex and oppose it at its place. And in the bed of Hoffman pocket, I tie the knots and bury it. And here is the real case. The Hoffman pockets are made, difficult rhexis, and place CTR hooks, MST hooks, do vitrectomy, place CTR, stabilize it, and then the main part. This is a Gore-Tex non-absorbable suture. I pass it through the ciliary bed, outer iris inside, outside inwards, eyelet of segment CTR is threaded, and it is put back. It's difficult to put because these needles are not a little bit thicker, and railroad it back in place and place the segment CTR in its place. So with one loop, the bag complex along with the iris are brought in its normal place, and you can place in the bag or you can place it in the sulcus also. So it's a single loop of suture taking care of both the dialysis. And this is a non-absorbable suture, and the knot is tucked inside the bed of the Hoffman pocket, inside the pocket. So it's a tucked in thing. That takes care of both the dialysis at one go. And literature does not report any such case till date. But in such traumatic cases, this might all will happen. It has reported such cases. The management has not been reported in these type. They have been treated on their own merits. The iridodialysis has been treated separately and the zonular dialysis has been treated separately. One just disclaimer that this process is going to work if the dialysis is about 30 to 40 degrees, not more than that.
It's a very nice technique. Only thing is you see that because you are having the CTR, the fixation, the eyelet underneath the iris and same time. And if you notice that pupil was little peaked in that area.
Yes.
Because you are actually tucking that iris along with that bag as well. So, and another thing is when I have a problem in the iris, I don't use Gore-Tex because it makes a big hole in the iris. That's a problem because it's a 6-0 Gore-Tex what we are using.
Gore-Tex is not meant for, it's an off-the-label use for ophthalmic use.
Yes, because for IOL bag fixation I use Gore-Tex. But for the iris fixation I use 9-0 or 10-0 Prolene. So, because already the iris is damaged in that area and you don't want to make big holes in the iris again.
But it has been staying there for
some
time.
I'm just telling you.
Yes, true.
Yeah. So
But
somehow it created multiple levels. That's what Dr. Mohan is trying to say, that going beneath the iris and then creating a SOP and then pulling it in. That's the reason.
I'm not pulling it very hard.
Yeah, but
they're titrating it so that it just in place. So that
I believe now
it should not cut
Gore-Tex is
through.
no longer much used. It was made very famous by Dr. Vasavda at one point of time. Now there are certain substitutes. Yeah, it also had its own problems. And what was the vitrectomy?
A pars plana vitrectomy was done.
So you did a pars plana
Limbal
vitrectomy
pars plana vitrectomy with a choker.
Okay.
Thank you.
Thank you so much.
So we move on to the next talk by Dr. Atulas Putalat on blue revolution. So blue is cool, dears. Let us see what Dr. Atul is.
You all must have faced problems and hence the need of innovation. We face difficulty in capturing images in ocular trauma, in chronic bedridden patients of the ICU, in infants for photo documentation, and in remote eye cams, it was difficult to capture fluorescein stained images. We thought to ourselves, what if we could find an attachment for smartphone that is low cost? What if this can be used by anyone, including all health assistants, doctors, and MLOPs? What if it is portable, pocket-sized, and easy in handling? What if it can capture good quality stain positive or negative images? So, what is Blue Patch? It uses the same principle as the C-Blue adapter. It is sticky on one side, it is made from gum paper, and is machine cut into precise circles. Let us see now how to use Blue Patch to carry out smartphone-assisted blue light photography. Patient's eye is stained with 1% sodium fluorescein stain. Any commonly available smartphone can be utilized. Take a blue patch from the strip. Now stick it onto the flashlight of your smartphone. Now your smartphone is ready for blue patch photography. Now bring the device closer to the patient. Use any camera app with the flashlight on. Dim the room lights. Ensure correct focus and capture the images. Let us see some sample images captured by the blue patch. This is a case of epithelial defect. And this is another case of exposure keratitis. This case had trauma with leaf and central infiltrates. Another case of punctate keratitis due to chronic dry eye. All these were captured brilliantly by the blue patch. Together, invent, progress in this blue revolution.
Thank you.
Nice jugaad. That's good.
Thank you, sir.
Thank you.
Any
Any
questions?
No.
Blue.
How thick or how?
And
So,
also wavelength or precise.
Yes, sir. So we have conducted some testing along with IIT Roorkee when I was doing my postgrad at AIIMS Rishikesh. So we have, even though it is not exactly the only blue wavelength, but it's a range. And the material and how it is made, because the patent has been under process, I am not able to reveal the entire details. But by the end of this year,
We would only like to know the principles.
So the principle is basically the white light from the flashlight is filtered and only the blue wavelength. But it's not exactly only the blue, but the range. So we cannot be as precise as a machine or a filter that costs so much. This is for teleophthalmology. Now SEVA has given us a grant, SEVA Foundation USA, and we have deployed this in vision centers, which comes under Aravind. And we have taught sisters on how to use this. They are using these filters, taking photographs, and sending it us back through the EMR, and the doctors sitting at the base hospital are able to diagnose or at least say, okay, refer the case to us. Maybe you can treat it, or also during camps.
So how little or how much is the cost?
So right now I am trying to bring it, I have a latest version which is reusable, so 50 rupee per filter.
Great, thank you.
Thank you, sir.
So now we are looking the last talk of the last day of this last session by Dr. Kumar. Dr. Kumar, we had almost 89 entries, and your number is 86. That's why you came in the last.
I thought you would go alphabetical.
So Dr. Kumar, doctor is going to speak on endocapsular ring insertion tips and tricks. Yes.
Hello friends, these are the tricks and tips for using an endocapsular ring. So trick number 1 is always place the endocapsular ring into the bag through the side port. So never use the main incision, and we glide it along the equator of the bag, and a bimanual technique to place the endocapsular ring into the bag itself. Now when we have to place an endocapsular ring, remember one thing, always start placing the endocapsular ring opposite to the area of subluxation, so that when the placement of the endocapsular ring is over, the two eyelets will come opposite to the area of subluxation, and it gives complete support to the area of the subluxation that is really necessary. Many times the confusion is to place the endocapsular ring before phacoemulsification and nucleus removal. Always place Helon under the CCC till the equator of the lens. Once that is done, we create the space between the anterior capsule and the cortical material, and then we place the endocapsular ring. Sometimes you need a Sinskey hook to guide this endocapsular ring inside the bag, and once this is done, as you notice, I am gliding it opposite to the area of subluxation. So when the endocapsular ring is completely in the bag, the two eyelets will be opposite to the area of the subluxation. So this is again a Bessett's T in the dominant hand, and the non-dominant hand had a Sinskey hook, and this bimanual technique makes sure, and you never fail, that the ring goes inside the bag. Sometimes we find that the endocapsular ring rotates over phacoemulsification. In such cases, under irrigation, we can actually rotate the eyelet, and to make sure that the area of subluxation is completely covered with the endocapsular ring. So here I got my irrigation on the bimanual. I got a Sinskey hook. I am hooking onto the eyelet and rotating and making sure that the area of the subluxation is completely covered with the endocapsular ring. So the final trick is to use the Bessett's T in the dominant hand and a Sinskey hook to glide the endocapsular ring into the bag in the non-dominant hand.
Yeah.
Thank you.
Good trick.
So what would you do if the subluxation is at 12 o'clock? Would you start threading it from the 6 o'clock or something?
I'm not sitting temporal, I'm always sitting superior in every
So you are
eye.
12 o'clock.
So even if it is my 12 o'clock, I'll still start from the side port. So I think that's my experience, never ever implant an endocapsular ring through the main incision.
Yeah,
There is too much play, there is too much moving around, wobbling around. So even if it's superior, I'll still do it from the side port, which is on two sides, and then rotate it and then bring it there.
So manual versus injector?
So yes, because of 2 minutes limitation, I've used the injector also. It works equally well. But remember, we can't use the Indian endocapsular rings in a Mosher injector. The Indian rings are quite stiff. So when you try to retract that into an injector, they tend to bend or break and change shape. So if you want to use an injector, then use the original endocapsular ring. Works beautifully and it's very easy to do. Only thing with the injector, the trick would be at the last step, you just, because it has to be unhooked. So that what the last step of putting the last eyelet in is again take something like an iris repository and just press it and it'll go into the bag. So this was without an injector, which anybody and everybody can do. It's a very simple trick and you will never lose. Many times what people realize is they lose the endocapsular ring into the sulcus. To avoid that, I use a T, which actually grips onto your endocapsular ring. Take your Sinskey hook and take it in and then just turn your hand. When you release the T, it just releases the endocapsular ring into the bag. So I think this is easy, that's why I'm just trying to make it simple.
Should work well.
Can I make a comment, sir? Kumar, as usual, brilliant. But what I do differently is, I do exactly whatever you say, but I do differently is when you have the trailing eyelet going in, what I do is I bring with a Sinski or a Kuglen hook right into the center of the eye. Then I hold that with a micro forceps. Okay? The micro forceps, then I, what you call the drop down technique. I drop it down into the sulcus. In that way, you go all the way to center and then bend it slightly posteriorly and drop it down into the bag. Okay, similarly to for example, I'm putting a multi-piece lens also, I drop it, I don't dial it inside. The only problem, of course, you are a fantastic surgeon, I'm just telling you, the only problem with putting a trailing haptic inside with the Sinski is that, again, you do not know where exactly it's going. Sometimes you may go a little anterior, sometimes you go posterior, where when you have a micro forceps, you have exactly know where it is and can go close to the capsular margin and leave it there.
Mohan, your one trick has taken more than 2 minutes.
So how many tricks you have shared in 2 minutes? 10 tricks?
4 to 5 tricks.
That's too much. Thank you. Thank you very much. And meanwhile, I think the results will be, yeah.
Hello, friends.
All presentations were really very good, and I would like to appreciate the youngsters more because they have very little experience and still did a good job. The more experienced ones, of course, have a lot of exposure. So really, congratulations to each and every presenter, irrespective of the results.
I think they are telling the results. And meanwhile, we can have the winner of Uttarakhand State video here. Can you have the volume?
Previously, surgeries like vertical slit, horizontal slit, 1, 2 or 3 snip surgeries were also advocated. Punctal plugs are also advocated as an adjunct to these surgeries. Plugs like binocular encerclage pigtail, mini monocle stent and binocular auto-stable intubation were all documented. Our bicopteran plug are very easy to make yourself and very cheap. Can be customized depending on the size that is required. If it can itself extrude, but if it can stay for more than 20 days, it does the work with normal punctum. How to make it? Wetfield cautery brought near the 00 Prolene stitch, it makes a knob there. And we cut the size according to the desired requirement, and a bend at the knob end is made by the heated forceps. It can be further customized by decreasing its size or increasing its knob size. If you need increased size, take another piece of Prolene stitches. It is very easy to put the punctal plug after dilatation and inserting a probe. Probe gives you the clue of the block if there is any, and the size of horizontal limb of the bicopteran plug. Removal is equally very easy. Even if the plug comes out after 20 days, it does the trick and the stenosis is not there again.
So it's over. Thank you so much. And a special thank you to all the honorable judges for having to bear with us. It's the last session of the last day. I think everybody's in a rush to catch a flight or train. Anyhow, thank you for bearing with us.
So next time at least give us our tickets back.
Yeah. I'll request not to put the last session as such. Yes.
In fact, I changed my tickets because of this session only. Otherwise, I was supposed to go in the morning.
So suggestions are welcome from all. How we can improve it further? It looks like a very close fight. So winner of this session will be awarded in the next AIOS that's going to be happening in Jaipur. No, Delhi. I'm sorry. Delhi. Yeah, that's why you're just remembering Jaipur.
Yeah, he's still under that impression.
Delhi was passed anonymously. We got around 89. Yeah, 89 entries there. Out of that, 14 were selected.
Dr. Arora, we got the results.
I'll request Dr. Grover sir to announce the results.
So, the winner, we didn't want to be very hackneyed and give the prize to the same person every time, but we were forced to give it to Mohan Rajan because he scored the highest. Unlike in time says 9.
Next time we are going to keep Mohan and the judges alike.
So, if Mohan Rajan graciously says that it should be given to the next one, then we go on to Dr. Atul S.
There are 3 actually, no?
Yeah.
3 at the same position.
There are 3 of them. Atul Uthalat, Dr. Kumar Doctor, and Dr. Ashok Sharma. Joint. So, Dr.
It's joined to 3 doctors.
Yeah.
Thanks, Dr. Mohan Rajan, for your magnanimity.
Just a photograph. All of the people can come here.
But property, आपकी property. 2. Malika 2.
2 minutes. Yes.
Thank you.
This is maybe the picture of the conference. No, you know this thing in Tamil Nadu? ADMK.
Okay. Absolutely.
You have to vote for Jayalalitha.
Who will send
Done.
to us?
We will vote.
Whose phones are those?
By Vinod Arora is responsible for getting the photos to you.
Sorry?
He is responsible for giving the photo to you.